Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome. This is fun and exciting. I have Dr. McCarty here, but he does not allow me to call him Dr. McCarty. He's my buddy, Dave.
Well, yes.
I mean,
you're like, hey, Dr. McCarty. I say, well, please call me Dave. Everybody does. And it sort of comes from my cartoonist background, but there's also a great story to it. And it has to do with my experience at Mass General. Do we have time to tell this story?
I want everyone to hear about this because sometimes doctors can feel intimidating, our MD colleagues, to patients and, other professionals like a myofunctional therapist, speech therapist. And when you said, call me Dave, I'm like, oh gosh, is that okay? So let's hear about why it's okay to call you Dave.
Yeah. Well, so again, this speaks to sort of my personal journey as a physician. If you read my work at all, my blog, everybody knows that I'm sort of an English major. I love words, and that's where I came from. But with that as my primary education, I decided to become a doctor later, a physician later. And so I had to go back to school to get my pre-medical requirements before I went to medical school. And I sort of carried into that this enormous, overblown sense of imposter syndrome the whole way. And when I found myself in the prestigious Massachusetts General Hospital internal medicine program, I just felt like I was completely out of my depth. This was one of the most prestigious programs in the world. I was surrounded by these giants of academia who were well published. And the thing that I remember from my intern year was the culture at that point in the internal medicine department was all of these wizened attendings. They would be like, I know it's not Dr. Call me Mort. And so it wasn't the great Dr. Mort Schwartz. It was Mort. I have this problem. Mort, who had been published in Scientific American a million times. So that made me feel somehow that I belonged there, that there was an intellectual egalitarianism to that I really savored coming in, feeling a bit like an outsider. And I realized that approachability is something vital in this age when we're trying to learn by collaboration, So it's in my website and the Empowered Sleep Apnea Project. It says, David E. McCarty, MD, FAASM, but you can call me Dave. That's how I kind of byline all my essays. And I mean it, because I mean to open up this discussion because, as I say multiple times in my work, this is a problem that crosses silos. It's expected to cross silos. We have to be able to talk to each other.
Yeah, that is so true. We have to be able to be open and not have a fear of authority figures, quote unquote, right? The doctors. And if we feel like doctors are so much higher than the patient, that leads the patient towards not asking all the questions, maybe not being as open, as honest.
Mm-hmm.
So I feel like that's such a cool thing, Dave.
So there you go. It's easier. It's easier when you practice. I have staff members that have worked with me for years, and they're like, I can't do it. I'm like, yes, you can. I bet you can.
That's funny. You can. It's so great. No, it really allows a sense of comfort. And that's so true. It's such a neat thing. And hopefully most people already know who you are because you spread the empowered sleep apnea message all over. I see stickers all over. Yeah, it is so awesome. So we're going to talk about that, but I'm going to go over your bio so everybody really truly grasps who you are and all you've done. And then we'll get into great conversation. So Dr. David McCarty is a sleep medicine specialist. So an MD, an award-winning educator, author, cartoonist, which is really fun. I love looking at all your cartoons that you've created over the years when you post things that you did back in the day. We want to talk about that. Also a podcast host. You're board certified in sleep medicine, graduated from Duke Medical School and Massachusetts General Hospital residency in internal medicine. Dave found his calling in sleep medicine after establishing a successful primary care practice. He studied the art of sleep medicine under Dr. Andrew Chesson at LSU Shreveport. How do I say that?
That's Shreveport. Say it with me. Shreveport. There you go.
I definitely butchered that one. Shreveport, joining the faculty upon graduation from fellowship and becoming the second program director for the sleep medicine fellowship when Dr. Chesson retired. Then, after 8 years of service at LSU in 2015, Dr. McCarty left academics to join the newly founded Colorado Sleep Institute, which is a collaborative sleep medicine practice which incorporated clinical management and diagnostic services, so sleep studies,
Mhm.
medical equipment, so PAP therapy, and dental treatment, oral appliance therapy, all under one roof, which is
Yeah.
great for all of
All
our
we
listeners.
did back then was MADs. The
Mhm.
whole pioneering strategies that are kind of very interesting today. It wasn't something that we were even getting our hands into then. We didn't know about it then, honestly.
Mm. So interesting. It was really PAP was the sort of gold standard, right? Treatment of
PAP,
choice.
basically PAP or MAD. I started to understand that there were other pioneers out there that were thinking about function and structure differently than just pulling the jaw forward. And so
Mhm.
I began referring outside of our practice when I thought that myofunctional therapy may be the answer. And,
Hmm.
it was all just within the sort of the understanding that, man, this is something that I don't know much about yet, but there's this person in town who does. And
Okay.
so I began to sort of explore these as a provider. And when I took I guess we'll call it a sabbatical now. At the time, I thought I was retiring,
Mm.
but at the time I took my sabbatical in 2021, my goal was to figure out how to explain this whole tapestry to everyone, so
Mhm.
that everyone who's in this, who has a seat at the table, whether that person is a standard Western trained MD, or that person is someone who knows and employs mandibular advancement devices in their practice, that this language would create what the whole amusement park looks like, so that everybody knows that it's not just their ride. There's lots of other rides, and maybe, heck, maybe this sounds like somebody who might be on do better on a different ride, and I know the people over there, and I like them because we all speak the same language. That was my vision in creating this project.
And you make that vision happen, and that's how you connect so well with patients and other practitioners, is because these analogies are so great, and you get that sense of there is not one fix, and there are so many dynamics involved in someone who has sleep disordered breathing. I'm going to talk about the part that kind of where you are now. So when you left in 2021, when you left the Colorado Sleep Institute, and you started this new journey, which is public education. So you
Mhm,
started the Empowered Sleep Apnea Project in
mhm.
2022, and I'm going to have you talk about that, and you'll talk about the book you wrote, which is
The
the
beautiful blue book.
beautiful blue book.
Yay.
Everybody needs to get this Empowered Sleep Apnea, and I want to talk about that book and sort of what your goal is and how you've changed, where you came from, and how you've changed your practice, your maybe motivation, your goals, and let's just talk all about that. So take it away, Dave.
Well,
The rest
I
is for
guess I'll
you.
I guess I'll start with a very dark period in my journey, which was when I left clinical practice. It was kind of I was despondent with the way things were happening. I felt like our system had become so fragmented that the same problems were happening again and again and again, because these different elements of the system were just, they had devised their own language for dealing with the complexity of this giant leviathan that we're all calling sleep apnea. So the medical equipment team that is outside your organization just does things differently, and the sleep neurologist down the street may do things differently than the sleep pulmonologist, and the airway associated dentist is now speaking a different language. And so if we go back to the amusement park, at the time that I left clinical practice, my perception was I am desperately working this ride that I'm in, and I can get people through it as long as I can kind of train them to understand where we're going. But for people that were not, that I couldn't talk to and help them navigate, it was like the Space Mountain. Oh, you don't want to go there. Those people are quacks. There's no data for that. And then when you go over to Space Mountain, they're like, "Oh, you must have been at Cinderella's castle, huh? Yeah, those guys are so full of themselves, and they just want to sell you a machine." And so all of a sudden, like, the patient just feels like, "Where am I? What is this that's happening?" And it feels very threatening to our patients. And often they jettison out and they disappear. I call this the negative space of clinical medicine. Is that if they become disaffected by a standard CPAP slinging medical practice and they leave, that medical practice never hears from that person again, because chances are they end up on a different ride where now they don't even trust the ride they came from because the rides are talking smack about each other, So for our patients, it is a treacherous journey that there is really no elevated guidance for anywhere that I've seen. And that's why I felt I have to explain this, because I knew, Nicole, my clinic, if I could spend about an hour with people and I could give them a basic understanding of what that amusement park looks like. And this is where we get to the 2 complexity deconstruction tools of sleep medicine that I use for the project, the 5-finger approach and the 5 reasons to treat. These are central to the whole empowered sleep apnea curriculum. And if you listeners or viewers who want to get into that, it's all on my website. So there's links to everything. But if I could sort of get people into that framework, and it's almost like giving them a whole map of like what Disneyland looks like from, 1,000 feet up. And they could be like, oh, okay, now we must be going through that part where I might need to talk to the folks at Space Mountain. And I'm like, yeah, I think so. So let's talk about what that's going to feel like. So they would be part of the journey and part of the co-discovery of where we're going to go, for the reasons that we all understand many moving parts involved with this problem, right? That's why it's complex. So there's many things that you might need to think about. So with that understanding, I could spend an hour with people, first visit, and I can get them oriented to what the amusement park looks like. And from then on, it's smooth sailing. Okay. And so this is where I'm at risk for sounding like I am being braggadocious. Okay. But because my patients were empowered in this fashion from the word go, the only patients that ever went on CPAP were the ones that chose to be there for the right reasons, because they were empowered. Okay. This is why I say empowerment saves. So with that understanding, we had a pretty awesome airtight follow-up program for our CPAP people at Colorado Sleep Institute when I was there, which means that everyone got started on a wireless modem. So we had access to their data 24/7 if we wanted it. And I did. And we knew, so we had a systematic way of going in and checking on compliance. So we had accurate kind of intention to treat compliance results, because even the people that went off site for their machines, we had their monitoring sent over to us. We were really good at tracking it down. So with all of that in mind, understanding that we could even follow up the ones who didn't come back to clinic, right? My long-term, I'm talking over years that I was there, long-term compliance and adherence rate with CPAP was in the low 90s percentile, like 92, 93% was pretty usual. And when we compare this to, like, whenever I go to a group, I sometimes ask, what's the long-term CPAP compliance rate? And if I ask dentists, they're like 20%, 50%. It's something really lousy. And of course, that's because those are the people that they see, the ones who can't stand it, and they come back. But the point here is not that I'm some sort of a magician. The point is that the empowerment, the patient, the empowered patient is going to stay on whatever therapy they're on, because they're going to be on it for the right reasons. But to empower that patient, it requires the ability to communicate a lot of complex relationships in a way that's not scary. And so maybe that gets me to the next part of the journey, which was I have this knowledge that this information creates an environment that's safe and empowering and ultimately more satisfying for the patient. And I know that I can teach it to them one at a time, right? So I'm like, I just got to teach everybody what I know. I'm going to put it in a book. And so this is in May of 2021. And so I'm sitting down to write my book. And we try and we outline, and I write for 8 hours, and I'm drinking coffee, and I'm going for walks, and I'm writing, and I get up in the morning and I read what I've written, Nicole, and it's dreadful. Because I'm busy trying to write a textbook with chapters and in an outlined format. And I'm trying to get across these very complex relationships by diagrams and stuff. And it gets to be, you get that feeling when you pick up a textbook and you're like, electrical engineering, that's kind of neat. And then you open it up and there's all this jargon and weird formulas and charts, and you're like, oh, okay. And then you sort of back away from it. You don't even want anywhere near it. And the truth is, what I had written was, well constructed. After all, I'm an English major, but it was just unreadable because there was nothing fun about it. And so I thought, and I had this idea that maybe this material needed to be conversationally committed somehow, because I knew that it worked in my clinic. You know, if I could sit one-on-one with most everybody, you know, if you had a high school education, I could teach you this stuff, and we would get through it one-on-one. So I figured maybe it has something to do with the verbal or the conversation or the drama. So I asked Ellen Stothard, who was the research and development director at Colorado Sleep Institute. So her background is she's a PhD in integrative physiology, who did her postdoc work in Dr. Ken Wright's laboratory at CU. And in case that name doesn't ring a bell, Dr. Wright is kind of in the lineage from Dr. Charles Czeisler from Harvard, the whole chronobiology. So he's a guiding light in the chronobiology world these days. So Ellen comes from his lab, and she's just a dynamic person, really sparkling personality, very incisive scientist. And I said, you know, if there's somebody who can help me dissect this, it's Ellen. And we, at that point, were acquaintances, you know, friendly, didn't really know each other that well. And so my immense gratitude, every time I see her, I tell her this, is that I cold called her and I said, hey, how would you consider doing a podcast? And she's like, okay. and she was game, you know. And so it was the podcast where we were trying to talk it out. It was episode 2, actually, where we had to do that episode 3 times because the first 2 times were dreadful. They were unlistenable. I had this idea of the curriculum I wanted to get out, and it was just not any fun. And so we had this moment where I'm like, man, maybe we should just what if we had like a treasure map that showed your way around this? Yeah. You know, because I was thinking about that state of mind the last time I was really interested in a book, like really like, oh yeah, I remember I was like 8 years old, you know, and it was Peter Pan. And it was that frontispiece of Neverland, that island, you know, where, you know, you could read parts of the book and they would mention a little piece of the island, and there it is. And there it is. And so that's why I drew that night, is after our second failed attempt at episode 2. Okay. And so we went back into the studio for the third attempt, which was successful. And I showed Ellen that map. And as we were talking about it, this is where the official unofficial slogan for this project was born, is that we're like, you know, if it's not fun, it's no fun. Mm-hmm. And why is anybody going to listen to it if it's no fun? You know, if it's not fun, it's no fun. And so we just really decided that to get this across, we were just going to explore the zany. And that was when we took that image and we put it in episode 1 and made it a framing sort of cornerstone for the whole project. And as soon as we did that, everything changed. The whole project changed. As soon as we assigned that to episode 1, we realized that this was a journey, that this had to be a fantastical journey. You'll notice episode 3, if anybody out there is a fan of the first season, episode 3 is when things really go into the Twilight Zone, and our narrator zaps into the dream world and he starts interacting with fantastical elements. I wanted that to be transportational. You know, I wanted to transport people to the frame of mind of what it feels like to talk about this. That space on our island is the coffee hut, right? That's the space where everything stands still. You got all the time in the world. No one is rushing you. No one is browbeating you. This is going to give you a stroke, so use your CPAP machine. You know, I've seen that happen before. People just get, you know, it feels like a browbeating, that type of an education. So what people need is an understanding of, hey, look, there are 5 reasons to treat. Let's talk about yours. Let's be reasonable about this and give you the space to explore whether this is something that needs to be treated at all, right? Yeah, so I went on and on. You got me going.
I love it. Your podcast, Empowered Sleep Apnea. So it's really fun. So I try to listen to podcasts when I go running. That's my time, which is kind of like meditative. I'm like in my zone, but I'm learning. So I listen to your podcast when I'm running some of the times, and it is so entertaining. All the sound effects, everybody needs to listen to the Empowered Sleep Apnea podcast. It's just so fun the way you guys kind of do like these sort of sound effects and in and out. I feel like I'm watching a movie or like a show.
That's great. Well, that's great. You came up with, so I wanted it to be cinematic. Like I wanted it to feel like you're getting this experience, because it's not just the knowledge, it's what does it feel like to get the knowledge? I realize that audio is
Like
it's a different medium, right?
totally. It's a good like Netflix documentary that I feel like I'm watching as I'm
Oh,
listening.
that's awesome. Well, thank
Because
you.
I'm not watching, right? I'm listening. You're there. So entertaining. And Ellen and you are just like really good counterparts, like
Yeah.
bouncing information off of each other, and then you're interviewing other people. Um, it's really interesting. And there's so much that you just went over that I'm like, oh my, so much to talk about. This treasure map. So the book Empowered Sleep Apnea is really entertaining. And exactly what you're saying, it's not like you're reading this boring textbook assigned, out of some school program.
Hmm.
It's for both patients and practitioners.
Yes.
And it really, I feel like it gives patients a way where they can understand everything about their journey in simple terms, but not downgrading. You're using the actual term, like what is UARS? What is AHI? What is RERES? What does all this mean in a way that everybody can understand? It's
Hmm.
like using the medical terms with all the entertaining pictures and drawings that go along with it. And your point of saying we can't force our patients into their treatment, we educate and then kind of like their team player, right?
Hmm.
That's what it sounds like. And I just love that because I feel like, at least with myofunctional therapy, we're sometimes that quarterback on the team because we are seeing our patients on a regular basis. And if you just empower them with the knowledge, with the understanding, and then help just be there with them throughout the process, that's a lot better than forcing them into information or this is what it is. And I think it's more rare that after I do an evaluation, I have a patient that does not enroll in therapy
Hmm.
because I take a lot of time, like that hour to 2 hours of explaining their case. What is sleep disordered breathing? What does it mean? What's going on? What are options? What all of this. And even if a patient was doubtful before they came in, or they're like, I don't know why I'm referred, but I'm going to do this. They're on board and they
Hmm.
almost listen to every single recommendation, advice, referral I give them. And it's almost mind blowing, but I really feel like you've given them the power and the understanding initially.
Yes.
That's what
Yes.
you're all about.
This is what I kind of saw when I first started this journey. I interacted with your myofunctional therapy group at the Collaboration Cures conference in Phoenix, and I wrote an essay about that at that time called "The New Idea," which was published in Cranio. I don't know if you've seen that,
Uh-huh.
but I realized at that time that myofunctional therapists get it. Like they are poised at a point when they've been taught the old understanding of what sleep apnea is. And when I say old understanding, the Pickwickian phenotype of floppy airway, sleep apnea, heart failure, needs a CPAP machine kind of sleep apnea. We now know that the term sleep apnea, I'll put it in quotes in my work, I just italicize it. But sleep apnea out there in the wild, I mean, it's a meaningless label because it means it can be a spectrum of things. And so if I say to you I have sleep apnea, you don't really have a firm picture in your head as a provider of what that looks like, smells like, is going to need, because it's a non-specific term, right? So one of my teaching points along this journey is that it's up to the provider to help unpack that complexity for the patient. And myofunctional therapists get it. They really do.
And part of it, I think it's because we work with a lot of different specialists. So if you almost picture one of those graphic organizers where it's like a circle, like almost like a circle sun with like lines coming out, we work with the ENT, the allergy doctor, the sleep doctor, all these other people. So we're kind of like, the dentist, the orthodontist.
You're the person who crosses over silos, aren't you? And so you're the
I
person who has
feel
to come up with language to talk about what you're seeing with all of these different people. That's my point, is that you're the ones who
yeah,
see that. It's
that's
almost like
really
you're riding in that blue balloon that's in my work. You
yeah.
can see the different silos and understand how people get caught in the middle too.
Yes, and I think that's such a good point, is that it's confusing for patients. It's very confusing. A lot of us have been there because we've had our own personal journeys with the sleep breathing aspect, and
Mm.
we kind of knew better because we're in the field and we can try to learn more and understand. But for me and my journey with my kids, I was very confused and I would have given up or listened to the one person that told me the one thing had I not known better. So I
Hmm.
think that helps guide our patients is to know this is an overwhelming process. And I want to talk about, you talk about complex versus complicated. And I
Yeah.
love that. It's really important to differentiate those two. So let us know the difference and why sleep apnea is complex but not complicated, or why we can think of it that way.
This is a great question because we're in the age of complexity. So when I use these two terms when I'm doing my speaking, teaching, complicated is going to refer to something that is, there's a lot of interconnected parts, but if you know what they are, and you do, you can get a linear result from that machine, if it were. So a complicated environment would be like the cockpit of a 747. Okay, lots of dials and gauges, levers, and stuff like that. Boy, that's complicated. And I wouldn't be able to work it, but a trained person could, right? And would be able to take off and land and get a pretty predictable result. So that's complicated. You need a professional who understands the machine. Okay. Now, this is the approach that we've been taking as professionals for a lot of medical problems. It's that we're professionals, we understand the machine, and here's what you need to do. So it's a top-down management approach. And that's the way a lot of clinics are set up. You go and you get your test, you get your AHI, that's diagnostic. You get counseled to use this machine, otherwise it's going to give you a stroke, and then you get a machine. And it's just boom, it's like a treadmill, or an assembly line.
Mhm.
And for patients who have a primary obstructive problem, and that's all they have, and this is probably like 50% of our patients are going to be like, yeah, it's the best thing ever. That's great. But to the rest of our patients, who disappear and never come back, and we can't learn from them, it's not okay. And the reason it's not okay is it's too complex for that. So what is complex? Complex means if complicated is a 747 cockpit, complex is a Peruvian rainforest. Okay. You don't know yet what you don't know. Oh, there's some ants there. Let's kill the ants. All of a sudden you've affected 17 other ecosystem and the tree dies, So you don't know how these things are related to each other. The reason sleep medicine is more like the Peruvian rainforest is that the syndromes involved and the diagnoses that we manage, they all overlap in terms of how they're experienced by the patient. Doc, I'm not sleeping well. Doc, I'm having terrible neurocognitive impairment symptoms during the day, right? So it's some combination of that. And that could be anything, man. It could be anything. There's a zillion and one and more than that things that can disrupt sleep or can create daytime neurocognitive impairment, or some combination of both. So if our machine is tuned to the label-based method of I feel crummy and I feel crummy and I can't sleep and I feel crummy, let's test you, label, and then you get into it's just like it takes over. And people get harmed by that top-down approach. So the way a complex environment is different and entered into, if we're using our Peruvian rainforest again, is it's done with probity. It is done with the expectation that you're going to get information back from your environment. And what that means as providers is we are working with our patients. And that requires a mutual understanding of the amusement park, what the whole amusement park looks like, and how to navigate the complexity of, non-specific sleep-wake complaints. Right? That's how I refer to it in my work. It's not just sleep-related complaints. It's not wake-related complaints. It's a combination. And when people describe their sleep-wake complaints, every narrative is a little different. So the task of the provider is not to decide whether you need a piece of plastic in your mouth. The task of the provider is to know how to operate within the ecosystem that's going to help that patient move from this perception of, sleep-wake problems to sleep-wake flourishing, healthful sleep-wake patterns. And understanding the whole amusement park is it's my first task. And people ask me, what would be the closing message? I would say, unpack the complexity first. Understand how this environment, this ecosystem all operates together first. That's your first step as a provider. After that, we can argue about which piece of plastic is the best one for the part of this ecosystem that you're affecting. I'm happy to do that all day long, and we'll demand data and we'll do all that stuff. But the first thing we have to understand is how this whole amusement park fits together, because it's we who has to shepherd that patient on a journey that is expected to cross silos.
And that complexity in that ecosystem is different for each individual person. Is that what you're saying? So we kind of have
Yeah,
to
you
understand
don't
that.
know yet what you don't know. And so the
Mhm.
patient needs to be part of the system that understands what you're looking for. And so now we get to the five finger approach. This is one of my 2 5-point mnemonics. The five
Mhm.
finger approach, for listeners, you find this in the interrupts. So five finger approach sleep. We'll get you to my article in the Journal of Clinical Sleep Medicine from 2010. It's called Beyond Occam's Razor. And basically, it's a way of talking about the person who feels bad, sleeps bad, feels bad in the daytime. Okay, well, let's create a narrative from that. And then let's explore the things that can go wrong together. So the five finger approach is something that you can read and internalize and use as a strategy all by yourself, but it works a lot better when you train your patient as to what you're doing and they can help you. Okay. And so the five fingers of the five finger approach are circadian misalignment. This is pretty commonly people get a social jet lag that creates a sleep onset insomnia and a sleep offset inability to get out of bed. So it can create and compound a lot of the other problems that we're working on. And if we don't know about it, we're going to over titrate the treatment that we do know about to try to fix what's still wrong with the patient. You see,
Okay,
so
wait a second. So a circadian misalignment. So from the poor sleep due to the sleep breathing issue, it triggers the circadian
no,
misalignment.
no, let's
Okay.
go back to the patient's perception of doc, I don't sleep well and I feel bad. Okay.
Okay.
The job of the provider is not just to recognize, oh, this could be a breathing airway issue. I mean, that's important. Okay. But we'll notice when we go through the five fingers, that's the pinky that we're going to think about that. I did that for a reason because it was my fellows that taught me we needed a system for this because stuff was getting missed after the person got diagnosed with sleep apnea. And it's like and I realized that this is just the way the human mind works with complexity is you cling to whatever structure you have. So if this is a person who feels like utter stinko, and you find that they snore, oh, I know what to do with that. And you put them on a CPAP machine. Now we're going to blame everything on that one problem. And so now we get to play the blame the patient game. When they come back, they're only using their CPAP for 4 hours a night because, hey, maybe you got it wrong. Maybe they've got a bad circadian misalignment problem and they put the CPAP machine on, they just can't wear it because you didn't help them address that. You know what I mean? And so we miss opportunities to intervene and help patients understand and self-navigate if they don't know what the playing field looks like. So generally speaking, when I would meet with my patients and they would come in and I don't know what to do, I feel terrible and I'm not sleeping well. And the CPAP machine isn't even working. Okay, let's talk about your narrative. What exactly is happening? And I usually start with, satisfied or no, yes or no. And that's a binary. And that just gives people a chance to air their grievances. No, I'm not satisfied. And then I always give them a chance to rate it on a 10-point scale because that just helps me understand how much they're suffering from this. And it helps me know which parts are the worst. Again, this is just exploration from the patient-centered perspective. And as soon as they score it, I know in an instant whether this is bad or not for them. And usually if it's a less than a 7 in my experience, because 7 out of 10 is it's a passing grade. It's a C. All of us kind of know that in the American system. And people who score themselves less than that, they're flunking themselves. And I usually note, I'm like, wow, you gave yourself a 4. That's a failing grade. Tell me about that. What about this is driving that? And that's when you find out what's really bugging them. Survey tools can only tell you yes or no, or maybe quantity about one thing, but it doesn't really give you any insight as to how this is affecting the patient's experience. So this just orients me as a clinician. It's like, well, the worst thing is the fact that I wake up sneezing 17 times a night. And you're like, oh, I didn't even know about that. Tell me more. And now all of a sudden you're in a different part, you're a different part of the problem solving than you would be if you just I see you snore. What's your Epworth score?
Yeah.
Very robotic. We need to sort of reorient that. The primary objective at the first step of this process is to establish what this patient's narrative is and help them see it. And so once I've got the patient's narrative into words, then I say, okay, so you've got 4 out of 10 sleep satisfaction because of persistent difficulty getting to sleep. Once you get to sleep, it feels light stage and you're tossing and turning, sometimes prolonged nocturnal awakenings. And when you wake up in the morning, you have a headache most days and you feel tired a lot. Is that right? Yes. That's it. Okay, good. That's your narrative. Now, the next question is, what's causing that? Are there more than one thing at play? It could be. So let's explore it. And so that's when I would usually teach people about the 5-finger approach. And so I'm just going to ask you a few questions about each of these to see if there's any signal, see if there's anything there we could do something about. And so, I query for symptoms of social jet lag, like people who are using screens. And I teach them about the 2-process model, usually at this phase, which is how sleep works. And if that sounds like jargon to the listeners, it's great fun to learn this, because once you learn it, you know it. 2-process model basically is how the signaling works. And I don't know if we have time to get into all this, but there are cartoons in the book that teach this. That's the reason it's important for this discussion, is to understand circadian misalignment. You have to understand the way the neurology of the chronobiology system works, and you have to understand the way the brain kind of uses its waking energy as power for sleep later. And once concepts, which is generally known as the 2-process model of sleep, once those concepts are accepted and understood by the patient, everything else within the cognitive behavioral therapy realm for insomnia becomes so much easier, because the patient gets it and they're like, okay, I understand now. So again, the empowered patient is much more likely to make choices that benefit them with you as their guide, and stick with them, much more likely than a person who is following orders blindly and doesn't understand.
And the 2-process model of sleep, is that just an understanding of the sleep-wake cycle?
Yeah, sort of. So, I could get into it. So the jargon is process S, process C. The 2 processes, okay, 2-process model. So process S, you can think of it as the homeostatic sleep pressure is kind of the jargony, sciencey words for it. But the idea is the more you are awake, the more physical stress you are under during the day, the more breakdown products of metabolism are being formed. Okay, we can accept that ATP is the energy molecule, right? You break down ATP to get energy. We learned that in biochemistry. One of the breakdown products of that is a molecule called adenosine. Adenosine is the most commonly recognized of the so-called sleep-regulating substances, which are all kind of elements of energy metabolism and inflammatory cascades. You can think of it that way. So stress on the system, okay? And adenosine is the best studied because we like to talk about it in sleep medicine, because when adenosine interacts with receptors in the brain, it makes us feel sleepy. Okay. And there's a molecule called caffeine that looks a lot like adenosine, and it fools the receptor. So when we drink coffee, the caffeine goes around and sort of sits in the adenosine receptors and says, haha, you can't sit here. And I'm not going to make the person sleepy though. And so you can have this buildup of increasing sleep pressure, so-called sleep regulating substances. And then when the caffeine wears off, that's when everything goes down into the basement. So the way I teach this in the book, and the way I used to teach it to my patients, is to sort of liken it to when you're awake and doing stuff, you build up fumes in the attic, and usually these fumes called sleep regulating substances if you want to look at it, but it's like fumes in the attic, and they make these kind of sleepy and cloudy. And if you get too many fumes in your attic, it's going to make you fall asleep whether you want to stay awake or not. Okay, so and it builds up in a linear fashion. The more you're doing, the more fumes you get. So when Lindsey Vonn, our Colorado sleep legend, right, goddess from the Olympics, was training for the Olympics, I read in a magazine article that she was getting 10 to 12 hours of sleep per 24, right? Because she trains like a freaking animal, right? She had all those fumes in the attic. And when people are like, oh yeah, that's kind of cool, they understand now that this is something they might have some control over. Now, if you're thinking about this though, you say, okay, so I'm building up fumes. How come right after lunch, I can't keep my eyes open? And then all of a sudden, like at supper time, I got a second wind. It's not like what's happening with my fumes then, smarty pants. And so this is a good way to introduce the idea that there's another process that regulates sleep and wake. And that second process is called process C for circadian. Okay. So here it's helpful to think about the fact that there are structures in the brain, in the deep brain, many of them, okay, and they're all together, they're collectively called the ascending reticular activating system, or the ARAS, ARAS. And those structures are responsible for making you a waked up person, okay? In other words, if we did an evil trick and we took an electrical probe and burned up each of those structures, selectively, we would create a person that is no longer able to wake up. That person would be in a coma. The EEG would probably show slow wave sleep only forever. So waking is structural. That's very interesting. Waking is structural. There have been stroke and encephalopathy syndromes where damage to these structures creates daytime sleepiness. Very interesting. Wow, that's interesting. It's instructive to know that we can selectively damage the structures of the ascending reticular activating system with intermittent hypoxia. Causes oxidative stress to these structures. So this explains the phenomenon of the person who has severe sleep apnea, who says, I'm finally ready to go on my CPAP machine because I can't stay awake anymore in the daytime. And we put them on a CPAP machine and it's perfectly managed and they are still sleepy. It's because they have damaged the ARAS. Okay. So now understanding that waking is structural, now we can say, well, that waking signal, it's not a light switch. It's not on or off. Okay. It's more like a dimmer switch or a volume knob that kind of goes up and down over the course of the day. Okay. Now we start to get an idea that maybe there's something going on that, oh, I get it. As my fumes are building up in my attic, we're actually getting a concomitant rise in the volume knob of the ARAS because no duh, it's keeping us awake despite the fact that our attic's getting fumy. Okay. And so when we look at this phenomenon, this leads to this place in the circadian cycle where it is very, very challenging to initiate sleep. Okay. And that place is actually sort of the 2 hours before your habitual bedtime. Okay. So that place in the circadian cycle is called the forbidden zone. Isn't that awesome? The forbidden zone. Starring Martin Landau.
That's actually what people call it, or do you call it?
No, that's what the circadian world calls it.
And great! So that's sounds like a U-turn. The forbidden zone. Yeah. Like it just that's awesome. Okay,
it's awesome. And so here's why this is important, though, because if you introduce phase delaying elements into the sleep environment, right? Phase delaying. What does that mean? Well, that means that there's a certain phase in your circadian or 24-hour cycle when your brain is like, okay, I'm going to allow a prolonged sleeping interval. Okay. So it's enough of a backing off of the ARAS that it just does it for a long enough period of time that it's going to allow it allows it to occur. Immediately prior to that period, which we'll call the circadian sleep phase. Okay. And immediately prior to that period is our friend, the forbidden zone. It was right before the circadian sleep phase. Okay. And it makes sense because that's when, you're kind of fumy in your attic, you're reaching the finish line of your day, and your evolutionary brain doesn't want you to fall asleep on your feet and get eaten by a moose, and so it's going to keep you awake until it's time for you to go to sleep. And that's all kind of tied into the light dark cycles of the world. It's supposed to be. So here's where technology and Thomas Edison kind of come into our mix. And that is we have sort of artificial light, and we're doing stuff that's activating. We're doing stuff that is generally indicative of daytime activity after the sun goes down. Okay. So if you want to imagine a scenario of someone exhibiting all of the phase delaying behaviors at once, this is somebody who is jumping around the room, eating a piece of pizza, talking to friends, playing a violent video game with all the lights on, getting real hot. So it's light, excitement, exercise, elevated body temperature, eating, socializing. These are all phase delaying behaviors after the sun goes down. So now let's do the experiment where we're gonna slide that timing of all of that later because we're delaying it with all these daytime messages after the sun goes down. We create an environment where the forbidden zone starts to become experienced when we want to get into the bed. And trying to fall asleep on top of the forbidden zone, like trying to get a beer at a frat party with the biggest frat boy in the world sitting on top of it. You want a beer, you got to go through me. You want to go to sleep, you got to go through me. And the forbidden zone, when it gets delayed, the experience that the patient is going to report is insomnia. I can't fall asleep. I am in bed for 2 hours and I can't fall asleep. And then, of course, they have trouble getting going in the morning. And that requires a lot of caffeine and stuff like that to compensate. And this particular flavor of insomnia is actually a circadian misalignment problem. And the patient will usually report that, oh yeah, I took that, whatever the sleeping pill was, Ambien. I took Ambien and it worked for one night, but then after that, it was like a sleeping pill, right? So that's a real key right there, because what happened is it'll work on the night when you are so sleep deprived and desperate that you've got so much fumes in the attic. It's like, okay, frat boy or no, you're getting your beer. Okay. But then after you're caught up on your sleep and now you're just trying to, push your way past that guy to get yourself a beer, he won't let you. It's called the forbidden zone because biologically it's hard to initiate sleep there. Okay. Your ARAS is working against you. And if it's not recognized, the reason I put it as the thumb of the 5-finger approach, if it's not recognized, it will cause treatment failure for whatever it is you're trying to do. You try and put a CPAP machine on somebody with that syndrome, they're going to look at you like you got 9 heads, and they're probably never going to come back. Unless.
Yeah, and I can only picture that would lead into like classical conditioning of you're putting the mask on in the forbidden zone where I can't fall asleep anyways. Now
Yep.
I have a sort of sympathetic reaction to
Yep.
the CPAP, right?
And now you're furious because you're sleeping worse than you ever have, because now you have this machine that's bothering you. And it's all because at the very beginning, we just didn't prepare the patient to explore this amusement part. So if this were done properly, this scenario, we would have been like, wow, it's taking you 3 hours each night to get, that's part of your narrative. This circadian misalignment, there could be some juice there, man. Maybe let's talk about how that works, and we'll work on that at the same time that we're thinking about these other things. That's the whole idea of the 5-finger approach.
And we're like stuck on the thumb because I love this with the 5-finger
approach. Well, the thumb is I put it as the thumb because it's foundational and fundamental to the entire sleep-wake experience biologically, and it's hard to talk about because it's full of jargon. And so if you can learn about the cartoons, I've got a tool on my website and in the book called the circadian rhythmo wheel that helps you understand this concept of circular time, and you can spin it around and see where things go and see where light affects you this way and this way, and that's something that's really useful for teaching these concepts to patients. I designed it like everything else for this project to be zany and delightful. So it kind of looks like a Cracker Jack gizmo. It's in there in the book. I don't know if you can find it in time and show it to the listeners, but
anyway, and I've seen you pass this out too. Of course,
yeah. It's a fun calling card because it's something that people can play with, and it sort of it gets people in touch with the project a little better.
And it also, this helps understand how cognitive behavioral therapy for insomnia can be more effective than medication.
Yes, it helps, right? That's the connection, Nicole. That's totally the connection. CBT for insomnia totally works. But in my experience, if a patient comes in and tells you, Doc, I've got insomnia. You say, great, we're going to do CBT. I want you to put yourself on sleep restriction. Tell the patient who is starving for sleep, literally, that our treatment for you is just to eat less, be in bed less, because that's one of the elements of CBT is sleep restriction therapy. And I'm not ridiculing it. It works. But the patients need to kind of understand this is something that we're using in order to maximize your chance of being a successful sleeper. So the way sleep restriction therapy is performed is you have them decide in the morning when they need to get up every day. That'll work for every day of the week. And this is going to be like respectful of their work schedule. So if it's like, I got to get up at 7 for work, and it's like, okay, done. You're getting up at 7 every day of the week. Now we're going to count back 6 hours. And 6 hours before that is when you get in your bed. We're going to give you a 6-hour interval. Now, notice what we've done. If we think this person is phase delayed and we think their forbidden zone is delayed, maybe their usual bedtime is 10 and they lie in bed for 3 hours, right? Fighting with that frat boy. Then what we're doing is we're allowing them to sort of get into the bed after that frat boy's given up and gone home. And they become a psychologically more successful sleeper right off the bat. And we also inform them that what we are doing is we are deliberately fumigating your attic right now. We're doing all of that good attic fumigation. And then we're going to do all of the stuff towards bedtime to protect you against those phase delaying elements. So we give them a little lesson in proactive wind down time, which is the opposite of that guy jumping around the room. It's sitting quietly with, indirect lighting and Robert Frost and chamomile tea, and Enya on the radio, So it's something that disengages the ARAS. It gets the ARAS out of the equation. It takes all of that light and excitement and all that other phase delaying garbage out of there. And then when the patient gets into bed, they are biologically ready, and plus they have all those fumes. And so often with 1 or 2 days of sleep restriction therapy, they're like, I get this now. And then we can start backing up their bedtime so that they can get the more prolonged sleep interval. But you see how the knowledge of all the fumes and how all that, it just makes more sense when people understand what's going on.
Now, I definitely want to get to all the other fingers. So I'm like scared to ask my question because it's keeping us on the thumb. But I'm curious.
Okay. No, I can go through them real quick. So the other 4 fingers are pharmacologic influences. So this is the checklist that to go through the patient's med list and look at everything they're taking pharmacologically, like prescription, socially. And there's an addendum in the book that talks about common substances that affect sleep and weight. Because again, we're on a quest here. We're trying to figure out, hey, this person has this narrative of all these things that they said are affecting their sleep satisfaction. We're trying to figure out what's wrong. So let's critically evaluate your med list, everything you're doing, and figure out, is it possible that this is part of the problem? And if so, there may be an alternate med that doesn't have that particular issue with it. Or there may be a way of taking that medicine in the morning instead of in the evening. Okay. So again, in the book, there's suggestions for how to navigate that. The middle finger is medical problems. So this is just calling attention to the fact when people don't sleep well, it is a sign that something is going on during the nocturnal time frame. And it might mean that other medical problems, often it's a painful medical condition. You notice pain more when you sit still and your mind is like, you're not having external stimuli. So often this is a call for an enhanced degree of comfort during the sleeping time frame from something that may not be completely curable. It may be a call to recognize other medical problems. So, when I'm talking patients through their sleep-wake experience, that's part of what we're getting is like, what's going on at night? Are you having a lot of pain? Are you comfortable? So we're getting information there. Ring finger is psychosocial, psychiatric, psychological domain. So this is a reminder for the provider and the patient to sort of think about whatever the narrative is with the lens of mental health and safety in mind. In other words, the person who complains of insomnia, I can't sleep at night, everything changes if the environment allows an exploration of what life is like at home. Are there gunshots outside the window? Is your ex-husband coming by and abusing you? This is just it's sort of a stopping point, like a surgical timeout almost is the way this checklist works in my head, that I don't allow myself to skip and say, I'll say, no, how are things going at home? Are you safe? Are you feeling like, so we can explore the patient's complaints through the lens of mental health. Finally, the 5th finger, the pinky, is where I allowed my fellows to explore the airway because they've explored everything else. And it's because I saw so much label-based care that a person with obstructive sleep apnea diagnosed would sort of not be explored anymore. And again, that's nobody's fault. That's the way the human brain works. The structure wasn't there to get into it. But so it's at the end, when we've sort of gone through this with the patient, we say, so now there are other primary sleep diagnoses that we commonly manage here. Things like restless leg syndrome, obstructive sleep apnea. Of course, there are mixed apnea syndromes. There are primary hypersomnia syndromes. There are parasomnia syndrome. So there's lots of other things that you might see in a sleep medicine textbook that are labels of themselves. But this tool was designed for people who are in the sleep space, so they would understand that now we're at the place where we're going to get to the stuff in the textbook.
This is so important. And we put airway as the last, the pinky, and I completely understand why. After you explain this whole thing, it's so true. Our patients, a lot of them have airway issues, but all the other 4 things we're skipping in many cases, because when they get the airway diagnosis, it's like, that's it. There we go. CPAP, oral appliance, whatever.
And that's what we're trained to do. And I think it's important that we continue to be trained to manage the things we know how to manage. But it's also important to understand that there is a larger framework to explore these ideas that everyone can actually learn. You might not be skilled in managing all of these primary sleep diagnoses like narcolepsy and things like that, but you're like, we're dealing with your airway and you're not feeling any better. And we checked your results and looks like we're getting so maybe there's something else going on. Let's talk about it using this structure. And you see, on the island of sleep apnea, which is usually where we would encounter this problem solving tool, it would be after the diagnosis had been made and doc, I'm no better. So on the island, I put it as 5-finger approach mountain thinking that this is an orienteering zone, that if you get lost, go to the mountain, and you can kind of
Yes.
go back and reorient and figure out where you need to go, and it can give you guidance.
That's great. Go to the mountain, go back to the mountain because you might be missing something at one of the prior steps that might not
Yeah,
have been addressed. And I just had a patient and I do the telemedicine appointment with him and his sleep doctor. And he did the sleep study and there's mild sleep disordered breathing. And he has
mhm.
cranial facial characteristics of someone with sleep disordered breathing issues. And he's a young guy, probably, I forget exactly, but early 40s. And, but he also has an issue with his neck that causes his neck to get pain, his arm to go numb when he's sleeping. And the sleep
Interesting.
doctor brought that up as that would be in number three, a pain or a medical problem that needs to be investigated separate from the airway issue.
And what's interesting is it could still be related, but it represents, because of course we know now that head position is related to airway
Yeah,
and desire to protect it. So we can develop neck issues as a result of sleep disordered breathing, but it's still an independent source of sleep disruption, right?
right.
If that's
And
if that's 90% of his complaint, we need to know that up front.
And we need to know, hey, let's not go down the dental orthodontic surgical route necessarily because we want to resolve these other factors because treating the airway might not resolve your sleep problem. And this patient in
Yes.
particular, it's good. I like to relate this to like stuff that recently happened to me or a
Yeah.
patient I'm seeing. I'm like, it's so clear. He's a swimmer. So he probably developed neck issues from being in hyperextension, also from swimming, but he also has poor posture from airway issues as well. So it's complex, but he needs to understand all the components to help him get the treatment. And I've explained these things to him. So he's going to see a PT and he knows all these things. And the sleep doctor said, we're going to put you on the CPAP. He's going to try that, but you have to understand, don't do any drastic surgical routes because there's other things that need to be addressed. And there's also the psychosocial components, the stress and the anxiety is also built into that for this patient. So this is a really great, this five-finger approach is really important for us as practitioners in any sleep field to understand, whether it's dental, sleep medicine, orthodontics, sleep MDs, myofunctional therapists, ear,
It
nose,
always
throat.
works.
It
I
works.
call it my favorite Swiss Army knife. I mean,
Yes.
anytime I get stumped, I'm like, okay, let's go back to the five-finger approach and
Whip out a finger. Yeah.
let's talk about this and figure out where we're going wrong. And it usually leads somewhere new, especially if the patient is like, I would draw this on the sheet on the exam table, and we would sort of go through each one. And the patient's like, it gets people in the game, and they want to understand, and they want to be involved in their care.
And
So
they'll come back for more. If what's not working, they're going to come back. But here's my question. And other people who aren't familiar with this might have the same question. This takes a lot of time, patient care time. And I don't think everybody's spending that much time with their patients to delve into.
this is where the Empowered Sleep Apnea Project comes in.
Okay, there we go.
So all these two complexity deconstruction tools, the five-finger approach, which we just went through, and the 5 reasons to treat, which are risk, snoring, sleep, wake comorbidities.
Wait, can we do that again?
Once
The
again,
5 reasons to treat.
5 reasons to treat sleep apnea. And the reason for this is if there's no reasons to treat, there's no reason to treat. So this needs to be something that the patient generates for their reasons to treat. So risk, some sleep apnea will kill you young. Some sleep apnea just irritates you. Okay.
Yep.
Obstructive sleep apnea, central sleep apnea. They're not all the same. Okay. So risk of early demise, things like risk of stroke can be discussed. But we have a lot of data surrounding sleep apnea, primarily the obstructive variety, and what that does to people long term. And the worse it is, the more likely it is to take you from us. That's the bottom line. Okay, so risk, snoring, second reason to treat. So snoring is a social irritant. Snoring is something that excludes intimacy. Snoring is something that is physically traumatic, that causes physical symptoms. So we can explore the burden of snoring for any individual patient, what it's doing to them. Sleep, third reason to treat. What is the sleep experience like? And you can see that now we can dovetail this discussion with our five-finger approach, sort of as we're discussing what their narrative is. We can understand, how does this affect your sleep experience? Is sleep up and down? Are you perceiving being asleep at night? Is this somehow doing something bad to the time frame when you were sleeping? So third reason to treat is sleep. Some people with sleep apnea perceive that they go to bed and they fall asleep easily and they sleep all night and no problem. Like they are dead asleep, dead to the world, no problem. And then they wake up, and then the wake experience may be something different. So that's why the fourth reason to treat is wake. It leads to a pretty prolonged discussion, or a nuanced discussion. Doesn't have to be long. A nuanced discussion of what is this doing to your waking experience: foggy headedness, irritability, behavioral disinhibition. You name it. Whatever the neurocognitive impairment is perceived, this is where we understand what is happening to the patient. And basically any flavor of daytime neurocognitive impairment can potentially, sleep apnea could be doing that to you, right? That's part of the discussion. And then the final reason to treat is comorbidities. Comorbidities are other diagnoses, the other stuff that we know sleep apnea tends to make worse: high blood pressure, diabetes, migraine headaches, irritable bowel syndrome, depression, anxiety, ADHD, on and on and on and on and on, TMJ, dysfunction. So all of these other health problems, once we line them up and we sort of say, so it turns out that all of these are issues that sleep apnea untreated is making worse, probably, or harder to manage, probably. And so you're needing more medication, or you're having more discomfort, or whatever. And if we manage a sleep apnea, it's possible these other comorbidities are going to get easier to manage or may go away. So once we line up the 5 reasons to treat, and the patient and the provider are capiche on that, they understand it, everything else happens in a more orderly fashion. The patient is no longer experiencing the pushback of, you've given me a label, I don't know that I trust you. All of this, the stuff that's a byproduct of fractured healthcare delivery syndrome, And the good news is that both of these mnemonics are available to everybody completely free. It doesn't require you to do all this training. It just requires you to understand it and speak the language. You can just tell the patient to listen to season 1 of our show, and it will give them basically a tour that allows them to understand what these tools are and how they're used clinically. And then the conversation that you have with them using these tools is going to be a lot easier.
Okay, so should listen to Empowered Sleep Apnea Podcast Season 1, and they're going to get a good grasp.
I did this for a reason. It's only 5 episodes.
Okay.
There's that 5 again. If you're into the whole numerology thing, apparently 5 is like a number that signifies that something new is going to happen. Probably because it's like it's the grabbing hand that does things, So there are 5 episodes, and in those 5 episodes, you will learn how to use those 2 5-point mnemonics, the 5 reasons to treat and the 5-finger approach. You'll learn what they are. It gives you the introduction to the circadian rhythmo wheel. There's cartoons in every episode, so you can kind of click into them, and in the show notes, it takes you to the cartoons that we explored for each one. And above all, they're a hell of a lot of fun, so it's not like eat your vegetables and you're like, ew. It's like, listen to this thing that's kind of delightful, and have a tour of the amusement park and come back and talk to me. And we'll all kind of go through this together.
Sleep apnea can be fun to treat, right? We can team up.
It is a lot more fun when we know what we're doing, and we all can see the whole complexity, and we all can work together,
And make it less scary for our patients. When we're like, we're in a team, we can fix this, we can figure this out one step at a time. Let's do this together. This is really interesting. I want to summarize a little bit what I learned before we end, because I know I took a lot of your time, and it's so great.
I'm so grateful that you let me on your program to say all this stuff. It's an important message.
I feel like it's so important. This is going to help so many people. So a patient can listen to this, and a practitioner, and get just as much out of this episode we just did. This is really good. So we talked about, well, first of all, the Empowered Sleep Apnea book. That is really a great resource for patients and practitioners alike.
Yes.
Either one, this is going to benefit both people. And your main points we talked about today was the 5-finger approach and the 5 reasons to treat someone with sleep disordered breathing and sleep apnea. 5 reasons to treat being risk of basically early death, snoring and the burden of snoring, the sleep experience that the patient's having, and also their wake experience, which could be different. Someone might have a poor sleep experience and a poor wake, or fine sleep experience but poor awake experience, and comorbidities that co-occur with sleep disorders like depression, anxiety, high blood pressure, things like that. So those would help grasp the patient to understand the 5 reasons to treat. And we know these reasons are complex. There's a lot of different interwoven characteristics. And then the 5-finger approach is there to help us as practitioners, whether we're MDs, therapists, dentists, orthodontists, whoever is on this team, understand the different levels and order of how we're going to address this with our patients. And this will help our patients understand their quote unquote disease and how, I don't know if you even like to call it disease, but this syndrome.
I like to think of it as a way of exploring the patient's narrative together.
Yeah.
And so you can think of these, if you go into a garage and it's just full to the brim of all kinds of stuff, and you don't even know what's in there, and you're like, oh God, there's a method to unpack, right? So we're creating 5 different boxes. And so we're starting to ask questions that when we see if there's any signal that there's something going on in this box, maybe we need to pay attention to this box. And the patient, meanwhile, is like grateful to understand that you're taking this apart and taking their complaint seriously and really trying to solve what's going on with them.
Showing you care versus this is a cookbook cookie cutter approach. So that 5-finger approach is circadian misalignment, pharmacologic influence, so how medications might impact our sleep and the way we're feeling, medical problems like pain or other things that might impact sleep quality, psychosocial and psychiatric components, and 5, which I'm counting this way, but it's reverse, pinky, being airway. Let's not jump right into airway, even though we know that is a problem for most of our patients. We have to unpack those first few.
Yeah, and 5 also includes other quote primary sleep diagnoses, things you might see managed in a typical sleep clinic. So narcolepsy, talking, restless leg syndrome, the types of things that you would expect to see in the International Classification of Sleep Disorders. Our version of the DSM-10 or whatever, DSM-5 or whatever that's up to now.
And that would be the pinky one,
So
5th.
pinky is just primary sleep diagnoses is how I termed it. That's where you're going to think about airway, but it also reminds you that it's not just airway, because central apnea is part of this, and restless legs and primary hypersomnias. The point being here is that if one doesn't know that those other kind of ways of thinking about these nonspecific complaints exists, it's inevitable that a provider who has one tool will overuse that tool to address the patient's concerns. And so the possibly over titrating to the point of harm. We do this with CPAP all the time. Let's turn the pressure up. I'm not feeling any better. Let's put the MAD forward a little more. So there are ways that we can make our wonderful treatments into something that are less wonderful if we're just chasing the same dog all the time. We have to know how to unpack it.
It makes you really realize, listening to this, how much is being missed for so many patients being treated with number 5 primary sleep diagnoses. So other issues, the airway or the narcolepsy or whatever. What steps 1, 2, 3, and 4, I think are being missed. I hope everybody can either get the book, listen to your podcast, learn more about this, because this is the best way to help our patients and help ourselves understand their conditions.
Empowerment saves. Empowerment saves.
Empowerment saves.
And we all are in this together, folks. This is bigger than one silo. We gotta learn to talk to each other with a common language. So that's what I'm trying to do.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much, and join us for the next one.